I'm Joe Graydon.
And I'm Terry Graydon. Welcome to this podcast of the People's Pharmacy.
You can find previous podcasts and more information on a range of health topics at peoplespharmacy.com. When people are desperately ill, whether from COVID or cancer, they want treatments. Why are good studies so crucial? This is the People's Pharmacy with Terry and Joe Graydon.
People facing life-threatening health emergencies are often willing to try almost anything, but some treatments may actually make matters worse. That's why well-controlled clinical trials are essential to learn what works for either COVID-19 or cancer.
Even when there are randomized controlled trials, it's possible to mislead doctors and patients with statistics. Citing relative risk reduction rather than absolute risk can be confusing.
How did the FDA commissioner fall into this trap?
Coming up on the People's Pharmacy, learn how to interpret data from scientific studies.
In the People's Pharmacy Health Headlines, the Centers for Disease Control and Prevention got a lot of attention this week by abruptly pulling down information it had posted to its website last weekend. The statement that's now missing acknowledged the role of aerosols in the spread of COVID-19. When the CDC pulled that statement off its website, it explained that it doesn't reflect the current state of knowledge and suggested that it was a draft that was posted by accident. In an opinion piece for the Washington Post, two experts on aerosols made it clear that the coronavirus can and does spread through aerosols. One of those experts, Dr. Lindsay Marr, was a guest on the People's Pharmacy last week. Why is this important? Because when we recognize the importance of aerosol transmission, we can protect ourselves by improving ventilation, changing air filters regularly, avoiding crowded indoor spaces, and above all, by wearing our masks.
Needless to say, the abrupt change in the website raised suspicions of political interference. A former FDA commissioner for the current administration, Dr. Scott Gottlieb, was quoted as saying, quote, "It's really hard to believe that this was an accidental posting of draft guidance that they had to subsequently pull down 48 hours later, that they didn't realize they had put it up over the course of the weekend." Dr. Gottlieb said this and previous reversals from the CDC that may have been politically motivated are deeply concerning because they undermine the trust that the agency needs to promote the public health.
Can you catch COVID-19 through your eyes? We don't yet have a good answer to that question, but a small study published in JAMA Ophthalmology suggests the possibility. Researchers in China reported that they had far fewer glasses wearers among the COVID-19 patients in their hospital than they would expect. The proportion of people wearing glasses in the general population of Hubei province was about 5 times higher. As a result, the authors proposed that glasses might be protective against the coronavirus. Another explanation may be that people who wear glasses might be less likely to rub their eyes. We do know that goggles or face shields are an important part of the personal protective equipment for healthcare providers. That doesn't mean a plastic face shield by itself will protect against COVID-19. Masks are still essential in preventing aerosol particles from getting into the nose and mouth.
There's still a lot of controversy regarding testing for COVID-19. Some tests take days to get results. Others are quicker, but potentially less accurate. Now, Finland is employing a unique testing strategy that's highly accurate and amazingly fast. The government is deploying trained coronavirus-sniffing dogs at its main airport in Helsinki. For this pilot program, participation is voluntary. It takes the traveler about a minute to swab the neck and forearms. Then, the dog sniffs the swab. Well-trained dogs are able to determine in roughly 10 seconds whether the sample is positive or negative. early studies suggest that such trained dogs may be better able to detect SARS-CoV-2 than standard PCR lab tests. What's more important, they may be able to detect infected patients before they develop symptoms and before they become PCR positive. Finnish researchers hope that if the airport experiment works, they may be able to use the dogs in schools, nursing homes, and other high-risk locations.
Does coffee have anti-cancer activity? Epidemiological research has suggested that coffee drinkers with colorectal cancer had improved survival rates compared to those who abstain. A new study in JAMA Oncology followed more than 1,100 individuals diagnosed with advanced or metastatic colorectal cancer. Data were collected from 2005 to 2018. This prospective observational study confirmed the earlier results. Coffee drinkers have a lower risk of disease progression and death. There was a dose-response curve, meaning that the more coffee people drank, the better the outcome. It didn't matter whether the coffee was decaf or regular. And that's the health news from the People's Pharmacy this week.
Welcome to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. In the middle of the COVID-19 pandemic, doctors have been desperate to find treatments that work, but there's a surprising shortage of scientific studies to guide them. To help us understand why we need well-controlled trials even during an emergency, we turn to an expert on medical evidence.
Dr. Vinay Prasad is a hematologist, oncologist, and associate professor of medicine at the University of California, San Francisco. His books include Ending Medical Reversal and his latest, Malignant: How Bad Policy and Bad Evidence Harm People with Cancer.
Welcome back to the People's Pharmacy, Dr. Vinay Prasad.
Thanks so much for having me back. It's a pleasure to be here.
Dr. Prasad, before we talk about your new book, Malignant: How Bad Policy and Bad Evidence Harm People with Cancer, let's talk a bit about treatments of COVID-19. You're a big advocate for transparency and clarity when it comes to drug trials. Dr. Stephen Hahn, Commissioner of the Food and Drug Administration, made a rookie mistake a few weeks back when he advocated for convalescent plasma to treat COVID-19 patients. What was his mistake? This notion of confusing relative risk reduction with absolute risk reduction.
It was actually more of a mistake within a mistake. So the mistake that you're pointing out is that Dr. Hahn confused a relative risk reduction, which has to do with how much more often in one group than another group something happens, with an absolute risk reduction, which really is what people think about as what's the take-home benefit to a therapy. And he portrayed it as an absolute risk reduction. It was a relative risk reduction he was talking about. And that matters because the actual difference was a lot less impressive than a 35% difference. But I call it a mistake within a mistake because the bigger mistake was the two groups he was comparing were really never meant to be compared to each other. It was a single study where thousands and thousands of people got convalescent plasma. After the fact, Dr. Hahn was looking at one subgroup of that study versus another subgroup. But that study was never designed or conducted to look at those two subgroups. And in fact, one could look at any number of hundreds or thousands of subgroups to draw a conclusion from. It suffers from the problem of taking data that was never intended for that purpose and doesn't actually answer the question. So the right answer isn't 35% this or 35% that. It's really, we just don't know if convalescent plasma improves outcomes for patients because they didn't do a study that could inform that question.
What would a study like that have looked like?
Yeah, I guess there's no getting around the challenging part, which is you got to have some people in the study who don't get convalescent plasma. If everyone's getting convalescent plasma, it's really hard to know what would have happened to them had they not gotten it. And the reality is with COVID-19 is that, very unfortunately, there's a group of people who are going to pass away of severe COVID-19. But thankfully, it's not everyone. And in fact, the glass is more than half full. More people are going to survive it than pass away from it. So I think the challenge with this kind of study where we just give people a treatment is we never even learn, despite giving it to tens of thousands of people, if it's actually worth giving, because we didn't have a group of people at the same time to compare them against.
Dr. Prasad, you've talked about the difference between try first and trial first. And, people are so desperate for something, anything that'll work against COVID-19 that they want to just throw the kitchen sink at it. Can you tell us why trying first is a grave mistake?
Yeah. Whenever something unexpected or terrible befalls us, there's a natural human temptation to just try doing different things. And you might be so tempted that you don't even try one thing in one person and one thing in another. You try 4 things in one person and 6 things in the other. But then you're left in quite a dilemma, because if the patient gets better, did they get better because of what you did, or did they get better in spite of what you did? They were going to get better anyway. If the patient passes away, did they pass away in spite of what you did, or did they pass away in part because of what you did? And that's the challenge with just trying first. If you just try things on people in sort of an ad hoc fashion without any rhyme or reason to what you're trying, you're going to get results that don't make a lot of sense. You don't know which of the things in the cocktail help the person, which hurt the person, which are necessary and which aren't necessary, or did all of it hurt the person? And that was really the mentality we were in back in March. Doctors around the world were just trying things, trying different combinations of things, some things that don't make a lot of sense. They didn't do what I think wisdom suggests, which is trial first. We do sense an urgency with trial first. We know we have to act, but instead of just giving things to everyone in this ad hoc way, we do it in a rational way. We'll give one thing to 10 people and have 10 people at the same time we're not giving it to, or 100 people, and compare. Well, did that one thing make a difference? Then let's try adding something else. Let's try substituting something. We can do these studies, but we need a group of people in whom we're not giving it to compare the results to. And that's called running a clinical trial. It's really kind of common sense 101, that if you want to know if something helped, what are you going to compare it to? And in the heat of the moment, it is natural for people to forget that for a moment. But I think what we saw with COVID-19 was they forgot it for a long period of time, and they forgot it for tens of thousands of patients. And what happens is, then you're left in a situation where you might not answer the question at all, and you might never know the answer.
So have we really kind of missed a great opportunity?
There is no doubt that much of the opportunity has been squandered to learn what can help. Now, thankfully, not all of the opportunity has been squandered. We learned that steroids in the right populations of patients with COVID-19 are life-saving. We've learned a little bit about remdesivir, this new expensive drug, but maybe not as much as we would have liked to learn. And we learned a bunch of other drugs that we thought were promising don't work, like tocilizumab and lopinavir-ritonavir. These were drugs that were hailed in the beginning of the pandemic as highly promising, and they didn't work. Now, we learned a few things along the way, but what I lament is that we could have learned a whole bunch more things. There's at least 10 or 15 more drugs we could have found out if they help or hurt, and we didn't learn that because too many doctors were just trying first instead of doing the trial first.
Dr. Prasad, we get a lot of traffic to our website, and a lot of the visitors have said, I saw a doctor on TV, and he said drug X is great against COVID. I mean, he's tested it on hundreds of patients, and he's really credible. And then we get pilloried for not getting on board with the program. Science seems to have taken a backseat to rumor, gossip, and innuendo. What's going on?
Well, I think when people are scared, where they're frightened, when they're facing something new, that opportunists, even con men, may come and take advantage of that. And you might see some of that even with people with credentials that you would think better of, even doctors, even scientists. I've heard so many scientists say that the solution to avoid getting COVID is pill A or pill B. And the truth is, this many months in the pandemic, we don't have credible evidence that any pill will lower your odds of getting COVID versus any other pill. There's nothing that the average person should be taking because we don't have that evidence. And yet we have so many people who charismatically say you ought to do X or you ought to do Y. And I can understand that as someone out there who may not know a lot about science, may not know a lot about medicine, it's tempting to say that makes sense. At least I'm doing something. I'm taking agency over my own body. That's a seductive thing. But the truth is, throughout human history, people have been fooled by people who make these claims. And the ones that are the most successful are the ones that they look the sharpest and they speak the most eloquently. But the truth is, you got to do the studies. And if you don't do the studies, then no one should really believe what you're saying.
And I think we can see this quite clearly in your field of cancer treatment.
I would agree. I mean, I think cancer treatment has long been a place where sick, vulnerable, dying, desperate patients have been seduced by healers, by doctors even, who promise them treatments that will alleviate their suffering and improve their longevity. Thankfully, in the last 50, 60 years, 70 years, we do have many treatments that really do work. They do increase survival. They do cure some patients. They do improve suffering. But we got a bunch of treatments that don't work. And we have had for thousands of years people offering treatments that don't work. So we've had a mix. Thankfully, in oncology, we do have some things that do work, but we've long had the opportunists and the con men.
I do want to ask you about randomized controlled trials. A lot of people have said, well, we're in the middle of a pandemic. It's a crisis. We need to just do stuff. Yeah. I mean, you don't jump out of an airplane with a randomized controlled trial on parachutes, do you?
No.
Or what about penicillin? I mean, hey, they didn't do RCTs with penicillin. Why can't we just be good observers and figure out what's working?
Yeah, that's a terrific question, and I definitely understand where it comes from. And I guess I want to say that if somebody did have a new treatment for COVID-19 that was a parachute, let's put that in perspective, what that would mean. A parachute is something that if you fall out of an airplane without one, well, your chances of survival are almost zero. There are a few case reports in the literature, but it's really zero. And if you jump out with the parachute, it's 99.9999% chance of surviving. That's a huge light switch effect. That's like a dark room and a bright light. It is clear as day. And if there was something like that in COVID-19 early on when the disease was ravaging in Wuhan, China, and researchers gave a pill to, let's say, 10 people, and they immediately came off the ventilator, stood up, said, "My God, I feel great. Thank you, doctor. You saved my life." If there was such an observation, it would have been told to us by now. But the truth is that all of the things that we were trying, well, at best, they might only have made a small difference because to the naked eye, you couldn't tell if people were much better if you gave them drug A or drug B or drug C. And that's the reality of medicine that's really hard to get across, is that we don't have parachutes. We're not in the parachute business. I wish we were, but biology is difficult, and there are not that many drugs that are like light switches. Most of our drugs offer small benefits. And when you got a small benefit, you don't know if that works just by watching 10 people. You got to give it to 100 people and not give it to 100 people or 200 or 300 and look to see for a small difference. And that's what we're dealing with in biomedicine. A COVID drug that reduces mortality by a couple percentage points, that is a really good drug. But you're not going to tell that from just giving it to 10 people. Your eyes can't see that. So that's why we need to do, randomized trials. And it's a lesson that one learns the more one follows medicine, that it's a lesson we've learned over and over again.
You're listening to Dr. Vinay Prasad, hematologist-oncologist and associate professor of medicine at the University of California, San Francisco. He hosts the oncology podcast Plenary Session and is author of the newly published Malignant: How Bad Policy and Bad Evidence Harm People with Cancer.
After the break, find out how patients can get accurate information when they get a serious diagnosis.
You're listening to The People's Pharmacy with Joe and Terry Graydon. The People's Pharmacy podcast is supported in part by CocoVia Memory Plus. CocoVia cocoflavanols support both cardiovascular health and cognitive function by promoting healthy blood flow, transporting oxygen and nutrients to vital organs and muscles, including your heart and brain.
CocoVia Memory Plus has 750 milligrams of cocoflavanols, the plant-based nutrients from fresh cocoa that have been proven to help boost memory.
CocoVia Memory Plus is backed by 4 clinical trials that demonstrate improvement in 3 different aspects of memory: long-term memory, spatial memory, and word recall. The studies show improved brain function in just 8 weeks.
You can try the benefits of CocoVia Memory Plus with a 25% discount off your first month. Use the code PEOPLES25. To get the full benefits, take it daily for 8 weeks. CocoVia is offering People's Pharmacy podcast listeners a 10% discount on subscriptions. That code is PEOPLES10. Learn more at cocovia.com.
Welcome back to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon.
The People's Pharmacy is brought to you in part by CocoVia Memory Plus, a cocoflavanol supplement backed by 4 clinical studies that show a significant improvement in 3 different aspects of memory. More information at cocovia.com.
Also by Verazana, an analytical laboratory providing home health tests for hormones, gut health, and the microbiome. Online at verisana.com.
Today we're discussing randomized controlled trials and why we need this kind of gold standard science to tell what works and what doesn't.
Our guest is Dr. Vinay Prasad. He's a hematologist-oncologist and associate professor of medicine at the University of California, San Francisco. His books include Ending Medical Reversal and his latest, Malignant: How Bad Policy and Bad Evidence Harm People with Cancer.
Dr. Prasad, you've pointed out that if we have a small benefit from a drug, we're going to need a pretty big trial to pick up that benefit and be able to tell whether it's really a benefit or not. In fact, it seems that the smaller the benefit, the bigger the trial we need. Would you comment on that, please?
Yeah, I think that's absolutely right, which is that if you have a modest benefit, a few percentage point benefit from a drug, you're going to need a trial that might be a few hundred patients. If you have an even smaller benefit, 0.1%, you might need a trial that's tens of thousands of patients. And I guess there's this tension in medicine, which is if you do a trial too small, well, it might lead to a result that's not very robust or reproducible. You can't really hang your hat on it. If you do a trial that's too large, you might find a drug that has a statistically significant benefit that's not clinically meaningful for the average person. It finds a benefit so small, it doesn't really matter in our day-to-day lives. So just like the story of Goldilocks, trials have to be the right size. They got to be powered so they give you reliable information, but they also got to be powered to detect differences that really matter to real people. And in medicine, we have all 3 of these trials. We got some that are too small, that are not conclusive, and some that are too large, that are chasing tiny slivers of difference. And we also have got some of the right trials. And I think the key about thinking about trials is trying to find those Goldilocks studies, the right size study.
Dr. Prasad, I'd like to get into the real world weeds for just a sec and talk about some examples. Yeah. So let's talk a little bit about a drug we've mentioned many times on the People's Pharmacy, and that is a statin, the most prescribed statin, atorvastatin. The brand name was Lipitor, and maybe 15 years, 20 years ago, there were commercials and advertisements for Lipitor, and in one of those ads, it said that Lipitor could reduce the risk of a heart attack or some sort of a cardiac event by about 36%. And that sounds really impressive. And I think most people reading that or watching that commercial, they're thinking, wow, like 36 people out of 100 will avoid a heart attack if they take Lipitor for like 5 years. But if you looked at the small print, it said, well, 3 people out of 100 in that clinical trial would have had a heart attack if they were taking placebo, and only 2 people would have had a heart attack if they were taking Lipitor. So basically, 1 out of 100 got benefit. Now, statins are perceived as miracle pills by cardiologists. And yet when you actually dig deep into the randomized controlled trials and you look at, how much time people get meaningful, you live longer, like maybe 10 years longer. Wouldn't that be great? Well, it turns out it's like maybe several weeks. Is that clinically significant? That's the question. Does that really have meaning for people when we talk about something called secondary prevention?
Yeah, that's a terrific question. I guess I would say, what you're asking is really sort of a big theme that's across so many things in medicine. And you've done a really terrific job of illustrating the difference between a relative risk reduction of 1 in 3 and an absolute risk reduction of 1 in 100. And those are the same numbers true in the same situation, but one has a different connotation, a different feel than the other. And I guess the answer is that I think there are many drugs that when one looks at it soberly, when one thinks about the absolute benefit it provides, how long you got to take it, the side effects it has, and this kind of bleeds into my work in cancer medicine because there are a lot of drugs like that in my field. And when you think about the side effects, the costs, the downsides, and then that small absolute benefit you're chasing, I think it's quite reasonable that some people come to that and say, it's not for me, doc. I appreciate you offering it, but I don't want to take that for me. And I think different people can reach different conclusions, and the role of a doctor is not to strong-arm a patient to take a medicine or to strong-arm them to not take it. It's really to provide that kind of information, the way you put it, in a thoughtful way that the average person can understand, and let the person make the decision for them. I think the example you raise is an interesting example, and in cancer medicine, there are many examples like that where people have to make decisions, and it's important to really understand what you might be gaining, but also what you might be losing, what the risks are and what the costs are.
Dr. Prasad, I think the idea of really knowing something about the side effects, the potential side effects of the medication that your doctor may be recommending is terribly important. And I think people sometimes have a hard time finding out about that because very often the randomized controlled trial that the drug company has done to determine whether the drug actually works doesn't tell us that much about the side effects. And yet that's what the medical professionals point to. They say, oh no, statins couldn't possibly cause muscle pain because it didn't show up in the randomized controlled trial. They're beginning to come around now and admit that some people do in fact experience muscle pain as a result of taking a statin. I am sure that this is also an issue in the field of oncology, where you have drugs that could be very toxic, and some people might experience side effects that didn't show up in the randomized controlled trial. How do you deal with that with your patients?
I think you are onto something, which is that randomized controlled trials, even the perfect ones that are done well, that give us information, they may not give us all the information we want. They might tell us that under some circumstances, a drug can improve some outcome, but they might not tell us under all the circumstances it will work. Will it work for everybody? And what are all the side effects that might happen in everybody? And I guess one of the things that comes up a lot in cancer medicine is that our studies are done in people who may be 10 years younger than average cancer patients. They may have no other comorbidities or take no other medicines, while average cancer patients might have a couple other diagnoses and be taking other medicines. I've heard one of my colleagues say that cancer patients on clinical trials are almost like Olympians who happen to have cancer. They don't look like you and I. They don't look like all of us. And what that means is so often that when you give a drug that has real side effects in a trial, in a cancer trial, in people who have tons of reserve and are otherwise in good health, and you start to extrapolate those results to older, frailer patients who may be taking other medicines, the benefits might get smaller, but the harms might get even larger, and they may have more side effects or not be able to take the medicine as long. Actually, in my book, Malignant, I detail many examples of drugs that they had a modest benefit in a trial, but in the real world, that benefit appeared to almost evaporate in some examples. And the harms were an order of magnitude higher. And I think one of the things that we can use to help identify those harms is we can use real-world data and ask things like, well, in the trial, they took a cancer pill for, let's say, 4 months. What's the average person prescribed that pill? How long do they take it in the U.S.? And it turns out in many of these studies I've even been a part of, it's often far shorter than the clinical trial. And so I guess the answer to your question is, the way I like to think about it, is all medicine brings side effects and harms. That's the guaranteed part. The question mark is whether the benefits are big enough to outweigh the downsides. And that is what the purpose of science and medicine has to be to answer that question.
Dr. Prasad, if we were to turn back the clock 20 years to your colleagues in the field of oncology and tell them that there would be commercials on television encouraging patients with lung cancer or breast cancer to ask their doctor for drug X or drug Y, they would look at us as if we were from another planet. Like, are you kidding me? Patients determining what cancer drugs they should take because of a TV commercial? No, not possible. And yet this happens now on a daily basis. There are many drugs that are advertised for things as serious as lung cancer or breast cancer, and patients are supposed to ask for them. I wonder if those 30-second commercials can really give patients the information they need to be able to make wise decisions about the latest immunotherapy.
That's a terrific point. I would say, as you know, the United States is one of those rare countries where pharmaceutical companies can directly market their products that require a doctor's prescription, to people in real world. That's something that only 2 nations on earth do. Many countries prohibit that because they believe that information is very difficult for the average person to make sense of. But we allow direct-to-consumer advertising in the U.S. 20 years ago, I think it would be reasonable, people would understand that they would be using that for things like depression, high blood pressure, heartburn, common conditions that the average person is facing. Those might be the kind of conditions that get direct-to-consumer advertising, that get ads during a TV commercial, say during the Super Bowl. Fast forward to 2020 and you're seeing ads that say, if you have non-squamous, non-small cell lung cancer, ask your doctor if immunotherapy is right for you. Well, that's a really small group of people. How on earth can the company justify having an ad for such a small group of people? As you point out, it's just a fragment of information. You don't really know, is it really right for you? But it raises the possibility you're going to ask that to your doctor. And there's some evidence that suggests that that kind of request may more likely lead to the prescriptions of those products. That's why they're doing the ad. But to your point, the first point I want to make is it says something about the cost of these drugs, that you can advertise to everybody for such a small group of people watching the TV speaks to just how much these drugs cost, how expensive they are. If they weren't so expensive and so profitable, they wouldn't get away with doing those kind of advertisements. The next thing it speaks to is whether or not the average person watching TV who may have lung cancer, but they may not know if they have that particular type of lung cancer the TV commercial's talking about. They may not know if it applies to them. They're getting that information. They're going to go ask their doctor about that. And I guess I don't know for sure if people are empowered by this information or if they're misled by this information. Are they put on a better path, or are they put on a path that's meandering and takes them away from best care? And I think we have to ask ourselves as a society, which is the answer to that question, because it determines whether or not we ought to allow that kind of advertisement.
Dr. Prasad, I would like to ask you about how we can empower patients with information. There are some people who, getting a diagnosis of something serious like a lung cancer or a breast cancer or a prostate cancer, they just say, "Doc, do whatever you have to do. I don't want to know anything about it." But there are also people who say, "I really want to know everything I can learn about this in order to make sure that what I'm doing is the best possible thing I can do." Now, I have seen your Twitter feed with a description to your medical students how to read a medical paper. Most patients aren't going to be reading medical papers, but some of the people with serious diagnoses are going to want to know how. What's the best way for people to really learn about their particular medical condition if they have just been diagnosed with something serious?
I'm really cognizant that that's such an important question. And because of that, I devoted a chapter of the book Malignant to this exact question. It's chapter 15. It's what can people with cancer do? And I guess the point of this chapter is just to talk to you about things that you should be asking the doctor, questions you should pose, and what to focus on in the visit that helps reorient care towards what's in your best interest, what will empower you. And I see a number of ways in which cancer patients can be put off the scent, to be taken down the wrong path. And I'll just give you one example, which is it's so easy when a doctor suggests a treatment to gravitate towards how that treatment might work. So for instance, if the doctor suggests an immunotherapy drug, the doctor might talk to you about how it unleashes the immune system and gets the body's immune cells to fight your own cancer. Now, that's a nice explanation. That's the kind of explanation that's really great in a science class. But it doesn't tell you what you need to know, which is, what are the chances that I'm going to feel better? What are the chances I'm going to live longer? And what are the side effects and harms? And one of the things I talk about in the book is how we can move from questions like how might it work to what does it do for me, and other ways you can reorient the discussion to bring the care back to you. But I think you're absolutely right that cancer patients and people who love them are some of the most important advocates in that doctor's office, and we should do everything we can to help them bring the care back to what's best for them.
Dr. Prasad, when people do get that diagnosis of cancer and basically the emotional impact is just overwhelming, if the doctor holds out hope, like, well, we have this new immunotherapy, and the very word immunotherapy sounds like magic. It's your body's own immune system fighting the cancer. It sounds great. And people are often willing to go down that road without truly understanding the risks because, hey, it's cancer. I'm willing to take almost any risk to get over this horrible disease. But talk a little bit about cranking up the immune system and what some of the reactions can be, because they can be, in some cases, devastating, if not deadly.
I guess I think there's even two parts to what you're saying. The first part about what you're saying is, how can we ask someone in a single visit, maybe with just 20 minutes, 30 minutes with a doctor, to go from being told they have a cancer, maybe even being told it's incurable, maybe being even told that they may not make it for more than a few years, to also being asked about what their preferences are for treatment, where they want to get it, when they want to come in, which of the treatment options make sense for them. How can we expect all of that from one person in 40 minutes? I think is a struggle with the system. And I almost reject at the outset the premise, and I like to, in my own practice, to take those discussions and as much as possible to have some on one week and some on the next week and some on the week after that, to take this very difficult situation and stretch it out, to really give someone the time to go home and reflect and to process and to think of the right questions and to come back and ask that. So that's the first thing I would say. The next thing I would say, to your point, which is immunotherapy a panacea? Is it a magic bullet? It, like all medicines, has real side effects, and some of the side effects can be severe. The body can have an autoimmune reaction against a part of the brain that is the master gland that governs all the hormones, can have an autoimmune reaction against the lungs. The consequences can be dire, even life-shortening. And that's true not just of immunotherapy, but of all the medicines we use in cancer. They are often double-edged swords. The same sword that can heal can also harm. And I think it's important that someone is allowed to have the time to process a diagnosis before they're asked to make all these hard decisions. And sometimes I would encourage people, as I discuss in the book, to ask for another visit, to come back another day and talk about that when you've had some time, because I think it's almost too much for many of us, myself included. I don't know how I would be able to do it all in one visit.
You're listening to Dr. Vinay Prasad, hematologist-oncologist and associate professor of medicine at the University of California, San Francisco. He hosts the oncology podcast Plenary Session and is author of the newly published Malignant: How Bad Policy and Bad Evidence Harm People with Cancer.
After the break, Dr. Prasad will share his unconventional views on diagnostic testing for cancer.
You're listening to The People's Pharmacy with Joe and Terry Graydon. This People's Pharmacy podcast is brought to you in part by Verizana.com.
Verizana Lab offers home health tests that allow you to monitor your hormones and health conditions. You can take control of the quantitative assessment of your health and learn about male and female hormone balance, the stress hormone cortisol, leaky gut, gluten intolerance, or your gut microbiome.
Take a more active role in tracking your health and take 20% off your first order of a mail-in testing opportunity with the discount code PEOPLE. That's PEOPLE, all uppercase. To learn more, go to Verizana.com. That's Verisana.com.
Welcome back to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon.
The People's Pharmacy is brought to you in part by CocoVia Memory Plus, a supplement with 750 milligrams of cocoflavanols, the plant-based nutrients from fresh cocoa that help support memory. More information at cocovia.com.
Also by Verizana, an analytical laboratory providing home health tests for hormones, gut health, and the microbiome. Online at verisana.com.
For decades, we were told by the American Cancer Society that the best way to fight cancer was with a checkup and a check. In other words, early detection. But are there unexpected risks to widespread cancer screening?
We're talking with Dr. Vinay Prasad. He's a practicing hematologist-oncologist and associate professor of medicine at the University of California, San Francisco. He studies cancer drugs, health policy, and clinical trials and better decision-making. He's author of the books Ending Medical Reversal and Malignant: How Bad Policy and Bad Evidence Harm People with Cancer. He hosts the oncology podcast Plenary Session and runs a YouTube channel, Vinay Prasad, MD, MPH. He tweets at vprasad, MD, MPH.
Dr. Prasad, you have aggravated a lot of your colleagues. I suspect a lot of radiologists when it comes to diagnostic testing in general and testing for cancer in particular. Can you tell us why it's fingers on the blackboard when you're talking about screening?
Well, I guess I would say that sometimes there are people you aggravate and there are also people you delight. And that's the interesting part about life, is that there are people who do like some of these ideas. But I guess one of the things you're talking about is cancer screening. And that's a tough subject because we all were brought up with that mantra, an ounce of prevention is worth a pound of cure. That a little bit of stuff on the front end, a little effort on the front end to avoid a problem later, always pays dividends. And if it comes to, say, your budget, your car, so many things in your life, well, that's absolutely true. A little bit of upkeep on the front end spares you a lot of trouble on the back end. But does that paradigm extend to finding cancer? Does it extend to biology? Is it always better to find cancer early? Should you look as hard as you possibly can? And that's the challenge with cancer screening, is that some cancer screening tests have been shown to lengthen our life and help us live longer and live better. Other cancer screening tests have merely been shown to change dying from a particular type of cancer, even though they don't have proof they extend our survival or our quality of life. And that's where I find myself in debates with my colleagues, is to point out that cancer screening is often sold to the public like it's an unalloyed good. But the reality is it often is more double-edged, and there are downsides and risks, and it may not be right for everybody, particularly older, frailer people who have other medical problems. And yet, in America, we've lived for decades in a culture that's exuberant about cancer screening. You know, we're so exuberant about cancer screening, we take ads that say things that are highly provocative. For instance, an old ad for the American Cancer Society told women that if you haven't had a mammogram, you might need more than your breasts examined. implying that they're crazy or silly for not pursuing this intervention. And that's the kind of uninformative persuasion we have in this field that dominates the field. And that's what I push back on. I think you got to arm people with information about the potential upside, but also about the downside and also about the uncertainties. And only then can you decide if it's right for you.
Well, I think the message that's been transmitted over the last 30 or 40 years is early detection. And I think the American Cancer Society used to have a slogan, a checkup and a check. Give us some money and we'll help cure cancer. The issue that has always been of interest to me was initiated by Dr. Susan Love, a renowned breast cancer surgeon. And she said, by the time you actually see something on a CT scan or an MRI or some other screening test, that tumor has probably been growing for years, and it's a systemic disease. The idea of, just localized breast cancer is probably a misnomer. And I found that really hard to believe, and I suspect a lot of our listeners had a little challenge with that message. Can you give us some sense of what we mean when we talk about early detection?
Yeah, I think when the average person hears early detection, they imagine a cancer growing steadily, and just before it jumps and goes from the breast to, say, the bone or some other part of the body, you catch it and you cut it out and you save a life. And that message and idea is seductive. And in fact, surveys show that people who have a cancer found from a screening test, well, of course they feel like the screening test saved their lives. But the reality is some of those tumors might never have made that jump, and other tumors that were found and cut out have already made that jump. And you're doing all this stuff when the horse has left the barn. And Gil Welsh and colleagues did a really terrific paper a few years ago where they asked that a woman who had a cancer diagnosis from a mammogram, what's the likelihood that her life was saved by that mammogram? And even giving every optimistic assumption into their model, their answer was still about 1 in 10. That 9 out of 10 people who have their cancer found, it was not going to save their life because that cancer wasn't going to spread, or it was not going to save their life because the cancer has already spread. And so that's the challenge with early detection. It sounds so perfect, but the truth is biology is messy. It's not like your car. It's not like your computer. It's not like other things in our lives. And it doesn't always do what we wish it did.
Dr. Prasad, one of the things that Gil Welsh has talked about, and I want to ask you about, is the question of the harms of detecting a cancer that does not need to be treated. But once you know it's there, how can you not treat it?
I think the word cancer is scary, and the moment someone is given that word, the impulse to treat it is there. I mean, I think if you detect a cancer that wasn't going to do harm to you in your life, you can only suffer the consequences of the intervention. And that might be biopsies and imaging to keep an eye on it. That might be surgeries or radiation or chemotherapy to try to cure it. And all of that stuff has side effects. It can change your long-term risk of other cancers. It can increase your risk of having a heart attack in the future. It has a lot of stuff it brings. So it's really important that the things we do find from screening are the things that were destined to do you harm, but by finding it early, we've averted that harm. But the truth is that despite all the advances in imaging and genomics, we do not yet have those perfect tests. We can't tell from looking at a cancer under the microscope whether it was one that was destined to harm you versus one that we now have interdicted on and we have stopped the harm. And that remains a deficiency of medicine that we ought to work on.
You talk a lot about conflict of interest in general, and I'm wondering if you can give us some insight as to why conflict of interest poses such a problem for medicine in general and in oncology in particular.
Yeah, conflict of interest, and by that I mean something specific, which is pharmaceutical companies that make $100,000 or $200,000 a year cancer drugs are giving lots of money to the doctors who prescribe those drugs. That's what I call a conflict. And it's a conflict because the doctor that seeing you, that ought to be making decisions purely in your best interest, is also financially beholden to the company that profits only from the prescription of those drugs and not prescribing it. That's the fundamental conflict, a tension in the soul of the doctor. And I think it is one of the most corrosive and problematic forces in medicine today. Just as an example, if you went to a court of law and it turned out that your attorney and the prosecutor were both being paid by the prosecution, you would have a problem. You'd say, my goodness, this person's not working for me. They're getting paid by the other side. Do I really trust them? And the same is true in medicine. If all of the stakeholders in medicine, all of the checks and balances in the system receive funding from the entity that's selling the drug, then does the system work in an impartial way, or is it skewed? Is the entire tabletop tilted? One of the things that people talk a lot about are the free lunches and free pens that doctors have gotten free for many years, which have finally sort of died out in popularity. Those things have been shown to influence decisions, but I'm not even talking about those things. I'm talking about the real conflicts, which are that the experts in cancer medicine who focus on rare diseases or certain diseases whose word is gospel and shapes the treatment and practice of cancer for many, many other doctors. These doctors are often receiving tens or hundreds of thousands of dollars a year in consulting payments from the companies that make the products. And as a result, one wonders when one reads the guidelines why we are so exuberantly recommending therapies that may have weak evidence or no evidence. Why are we so enthusiastic about these drugs? And I think that some of that has got to be that the people making those recommendations are not doing it from an impartial place. They're doing it heavily influenced by the industry.
So our listeners are going to want to know, does Dr. Vinay Prasad take money from the pharmaceutical industry?
I don't take money from the pharmaceutical industry because I believe it is a tension that no one can resist. It doesn't matter what you believe your values are. It is not tenable to receive money from an entity without, to some degree, being subconsciously influenced by that money. That's been shown in a number of psychological studies. And for that reason, I personally do not participate in those arrangements.
Dr. Prasad, ideally, the patient is able to trust the doctor who is treating him or her. But if a patient has questions, is there any way for them to check and see whether the doctor is actually being paid by the pharmaceutical company?
Since the Affordable Care Act, there is a website called Open Payments, and it's run from the Centers of Medicaid and Medicare Services, or CMS. It's a public website, and a patient can look up any doctor who is seeing patients in the United States. There's some omissions that people who don't take care of patients, PhD researchers, other academics who don't see patients, they're not in the database. And also companies that have a drug in the pipeline, but they don't have it on the market yet, they're not in the database. But patients can look up doctors for the common companies on this database. It's called Open Payments.
Dr. Prasad, you are a strong advocate for evidence-based medicine. And really, who can criticize evidence-based medicine? But as we've already talked about, many of the clinical trials that lead to FDA approval may only demonstrate a very small benefit. They may not be clinically based or clinically helpful, even though they may be statistically significant because 10 or 15,000 patients were in those clinical trials. And I'm now thinking about drugs for Alzheimer's disease, which have been approved by the FDA, but quite candidly are not terribly effective. We have antidepressants that help some people a whole lot, but when you look at the clinical trials, the actual degree of improvement is only a little bit better than placebo. So I wonder how you balance evidence-based research from really what I call clinically based research, where the benefit is really apparent to both the patient as well as the clinician.
I think it's a tough question that we face today, which is that what we want and what we're getting are not the same thing. Each year, the FDA proudly proclaims that we've approved 20, 30 new drugs for cancer. Look at all that innovation. But those are just choices. What patients want and what doctors want are good choices. We want drugs that transform outcomes for people, that don't just add 10 days of survival, that don't just change the way tumors look on CAT scans, but add years of survival to people's lives, that greatly reduce their pain and symptoms. And that's what I think you're talking about, clinically meaningful drugs. That's what we want. And I think the challenge we face as doctors and patients is we live in an ecosystem where the regulators, where the politicians who drive the regulators are lowering the bar for what products can come to market. And that creates the appearance of innovation. There are many more things than they were before, but not all those things are transformative. Not all those things do what we wish they did for patients. And I think it's a tension that works its way all the way to the doctor's office, where it's often difficult to counsel a patient about should they or should they not try a new pill when all we know about it is if you give it to 50 people, 20 of them have tumors shrink. Well, do they live longer, doc? Do they live better? What are all the side effects? Those are questions we can't answer. And that leads to very tough discussions and tough decisions for people. So in a way, I actually think our permissive attitude, approving drugs too early, actually it deprives people of choices because they don't have the choice to make a decision that's informed. They just have options, but they don't have good options. I think it's a perverse way it works out.
Dr. Prasad, what is the most important message our listeners could take away from our conversation today?
I wish we lived in a world where everybody participating in healthcare was not tied to other entities financially, looked at things impartially, and asked always and most importantly, what was best for the person in front of them, for the patient. I wish we lived in that world, but there are a number of perverse ways in which we don't live in that world. That incentives are slightly skewed. They're misaligned. They favor profits, short-term profitability, over long-term patient outcomes. They favor uncertainty over knowledge. And those systemic failures require a two-pronged solution to fix. One, that a person going to see their doctors got to be empowered, got to go with a friend or loved one, ask the right questions, and try to get the best care for themselves in the system we live in. And two, that person and all of us have to fight to reorient the compass of care back to the person in front of us. We all have to make this a better system. And healthcare is something complex and often boring and dry. And it's upon all of us to do our best to try to understand the failings and think about what we can do to make it better, or it's not going to be better for the next generation.
Dr. Vinay Prasad, thank you so much for talking with us on the People's Pharmacy today.
Thanks for having me.
You've been listening to Dr. Vinay Prasad. That's Vinay Prasad. He's a practicing hematologist-oncologist and associate professor of medicine at the University of California, San Francisco. He studies cancer drugs, health policy, and clinical trials and better decision-making. He's author of numerous academic articles and the books Ending Medical Reversal and Malignant, How Bad Policy and Bad Evidence Harm People with Cancer. He hosts the oncology podcast Plenary Session and runs a YouTube channel, Vinay Prasad, MD, MPH. He tweets at vprasad, MD, MPH. If you didn't catch those details, you'll find them on our website.
Lynn Siegel produced today's show. Al Wodarski engineered. Dave Graydon edits our interviews. B.J. Liederman composes our theme music.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC.
The People's Pharmacy is brought to you in part by Verazana, an analytical laboratory providing home health tests for hormones, gut health, and the microbiome. Online at verisana.com.
And by CocoVia Memory Plus, a cocoflavanol supplement backed by 4 clinical studies that show significant improvement in 3 different aspects of memory. More information at cocovia.com.
To buy a CD of today's show or any other People's Pharmacy episode, you can call 800-732-2334. Today's show is number 1228. The number again, 800-732-2334, or on the web at peoplespharmacy.com.
When you visit the website, you can share your thoughts about today's show. We have links to Dr. Prasad's articles, books, and podcasts. You can subscribe to our podcast through Apple, Stitcher, Google, or your favorite podcast provider. It's posted on our website every Monday morning.
At our website, you can sign up for our free online newsletter to get the latest news about COVID-19 and other important health stories. In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thank you for listening. Please join us again next week.